to the next topic, which is pre-recorded. Professor Papadakis, who is a well-known professor of cardiology at St. George's University, is going to present the topic cardiomyopathy, high-risk genes in sports.
Good afternoon, ladies and gentlemen. I would like to take the opportunity to thank the organizers for the very kind invitation, and I'm really sorry I couldn't be physically with you today. So the subject I'm gonna negotiate is about high-risk genes and sports. So I'll start briefly by introducing when to perform genetic testing in athlete, and the honest truth is that it's very similar to your usual clinical practice. So you need to consider genetic testing when it's actually going to make a difference. So you need to think of the clinical impact. And it is usually after comprehensive clinical evaluation of the athletic individuals in the context of a clinical phenotype. But occasionally, it may be in the absence of a clinical phenotype or comprehensive evaluation in the context of a familial evaluation, what we call cascade testing. So relatives who have the phenotype, they were identified with a pathogenic or likely pathogenic gene, and now our athlete has the opportunity to be tested. So in terms of the main clinical scenarios, will be an athlete who has a definite diagnosis of an inherited cardiac condition. The second clinical scenario, which is the most challenging one, will be an athlete who falls in that gray zone. As you know, regular physical exercise results to a lot of adaptations, and an athlete may have left ventricular hypertrophy that overlaps with hypertrophic cardiomyopathy, dilated cavities which may overlap with dilated or arrhythmogenic cardiomyopathy, or significant T-wave inversions on their ECG. And the third one is the family that we have identified the genotype, and were able to offer the athlete gene testing in the context of familial cascade screening. So let's start with a case that highlights the challenges that we face. I've got for you a 23-year-old recreational footballer and runner. He's completely asymptomatic. He has no medical history. Both parents and his younger brother are alive and well with no other family history. And he attends one of our CRI screenings to get a 12-lead ECG prior to running the London Marathon. Now, this is his 12-lead ECG, and you can clearly see that it's very abnormal with T-wave inversions in V1 to V4, a slightly inverted T-wave in V5, and also T-wave inversions in the inferior leads. We go on to perform a transthoracic echocardiogram, and it's quite clear here that there is a very dilated right ventricle, which is poorly functioning with reduced longitudinal and radial function. So this, in the context of the ECG, immediately raises suspicion of arrhythmogenic right ventricular cardiomyopathy. Indeed, the cardiac MRI confirms the echocardiographic findings, and here you can see even more clearly how dilated and poorly functioning the right ventricle is. And when he gets on the treadmill, we identified multifocal ventricular ectopy with episodes of non-sustained VT coming from the RVOT in this particular occasion. And on his Holter monitor, he has further episodes of non-sustained VT and a relatively high burden of ventricular ectopy for such a young individual. So he gets diagnosed with arrhythmogenic right ventricular cardiomyopathy, and we proceed with genetic testing, which identifies the pathogenic plakophilin 2 variant. Then this is his family, the two parents and his 17-year-old brother, and they undergo familial cascade screening after appropriate counseling, which is extremely important. Pre-test and post-test counseling should always be done with caution and by people who have the right experience and expertise. And essentially, his mom and his younger brother are identified to carry exactly the same plakophilin 2 pathogenic variant. His mother has a mild phenotype with some subtle abnormalities on her 12-lead ECG, a relatively low burden of ventricular ectopy, and no overt structural changes, while his brother has a completely normal ECG with normal comprehensive evaluation, which included an echocardiogram, a cardiac MRI, maximal exercise testing, and an ECG monitor at rest and during training sessions. Now, the catch with his brother is that he is a very good football player who plays for the youth academy of a good team, and his aspiration is to become a professional football player. And the question then becomes, what are you going to advise his brother? He's genotype positive, but he's phenotype negative. Should he continue with his aspirations at such a young age of becoming a competitive football player, a professional football player? And we're asking the question because we do have significant concerns in terms of the relation of exercise and arrhythmogenic right ventricular cardiomyopathy. If you have defective desmosomes and you subject your right ventricle to the stresses of high-intensity exercise, then there is evidence that suggests that people may present at a younger age. They are at high risk of ventricular arrhythmias, and more rapid progression to heart failure, and potentially to greater risk of sudden cardiac death. And it appears that this is true even for genotype positive, phenotype negative individuals based on existing studies. I will focus on the study by Cynthia James and colleagues, where they took 87 carriers with pathogenic variants for arrhythmogenic right ventricular cardiomyopathy. The great majority of them were of the plakophilin 2 gene, as is our athlete. And this is because it's one of the most common variants of arrhythmogenic right ventricular cardiomyopathy. And what they did is they interviewed them in terms of exercise from 10 years onwards, trying to assess the volume and intensity of exercise they were performing. And they looked at the likelihood of exhibiting an RVC phenotype, arrhythmia, or heart failure. In terms of the definition of endurance athlete, it was 50 hours per year of endurance sports with high dynamic demand, okay? And the athletes did about 400 hours per year, which is about 8 hours per week, while the non-athletic group exercised for roughly 2 to 3 hours per week. And what they identified is that athletes were far more likely to exhibit diagnostic criteria for arrhythmogenic right ventricular cardiomyopathy. And you see that there is a bit of a exercise dose increase of the likelihood of fulfilling RVC criteria. And on the other hand, athletes were more likely to experience arrhythmias and more likely to progress to heart failure. And as such, the recommendation from the European Society of Cardiology is that participation in high-intensity recreational sport and all competitive sport is not recommended in individuals who have an arrhythmogenic right ventricular cardiomyopathy phenotype, but that includes also those who are gene positive but phenotype negative, which will be our athlete. So RVC is not compatible with competitive sport, even for genotype positive, phenotype negative individuals based on the ESC guidelines. And they also highlight particular variants such as the DSP and the TMEM43, as well as carriers of multiple pathogenic variants as higher risk individuals for arrhythmias that should be monitored frequently. What does the ACC and AHA say? They take slightly different stance, and they also attempt for the very first time to differentiate exercise advice based on the genotype. So they say that based on the evidence we've got, which is predominantly on plakophilin 2 variants, athletes who have the phenotype of ARVC and the genotype is of the plakophilin 2 variant should be advised against high-intensity competitive sport, while those who have the phenotype but it's of a non-PKP2 variant may be considered for participation in competitive sport after comprehensive assessment and shared decision making. The other thing that they highlight is that for athletes who are genotype positive for arrhythmogenic cardiomyopathy but without a clinical diagnosis, it is reasonable to consider participating in competitive sport after expert assessment, where you explain to the athlete what the potential risks are based on the studies that we've got available, and you surveil them closely in terms of developing the potential phenotype. So ARVC may be compatible with competitive sport based on the ACC and American Heart Association. So if we look at our athlete, on one side, one may argue that genotype positive does not equate to disease. There is increased risk, but does not equate to disease. We've got the ACC and HA guidelines that are more liberal and will support in a decision to continue with competitive sport, and obviously the importance of competitive football in his life. On the other hand, however, we've got the evidence, even if it's retrospective observational evidence, that suggests that there is a significant risk. We've got the ESC guidelines and the very young age of this particular individual who has the potential to develop arrhythmogenic right ventricular cardiomyopathy. If he were to continue, then close monitoring is highly advisable, and educate the athlete in terms of symptoms and looking after himself. And also don't forget that sometimes it's far safer for athletic individuals to participate in organized competitive sport where there is emergency planning rather than playing recreationally outside the context of organized activities. What about other potential genotypes? And this is a study looking at laminopathies in dilated cardiomyopathy, and very similar principles. They had 69 patients with lamin AC pathogenic variants. Some of them had the phenotype, some of them were genotype positive, phenotype negative. They tried to assess their exercise history. The definition of an active individual was about 4.5 hours of exercise per week. And essentially, they tried to look if active individuals with lamin AC were more likely, compared to more sedentary individuals, to present as probants at a younger age with a lower left ventricular ejection fraction or more likely to exhibit atrial fibrillation. And if we look at the ejection fraction, you will clearly see that the higher exercise in terms of hours per week was associated with a drop of the left ventricular ejection fraction in both patients who had the lamin AC, as well as family members who were genotype positive, phenotype negative, and a very similar theme in terms of progressing to a left ventricular ejection fraction of less than 45%. And if we look at that in the family members, so those who were genotype positive but phenotype negative, that was more likely to happen in those who were more active compared to those who were more sedentary. So what do the guidelines say about dilated cardiomyopathy? The ESC guidelines are liberal for those who have a mild phenotype, but they put a word of caution for those who have high-risk mutations such as lamin AC or filamin C, while the ACC and HA is more liberal, as with ARVC, in terms of those who are genotype positive but phenotype negative. And this is a study that was recently published trying to look at filamin C truncating variants. Again, a retrospective cohort, 45 probants and relatives carrying the filamin C truncating variants. They collected data in terms of exercise, over 5 years. There were 9 individuals who experienced life-threatening arrhythmias, and they found that there was no significant association between the history of higher intensity exercise and increased risk of arrhythmias or increased risk of progressing to left or right ventricular systolic dysfunction. But they raise a word of caution as 3 individuals who were phenotype positive, mostly with dilated cardiomyopathy, they experienced life-threatening arrhythmias, and all 3 of them were during intense exercise. So in conclusion, ladies and gentlemen, genetic testing can be extremely useful when utilized correctly in the field of sports cardiology, and it has the potential to personalize medicine. It goes hand in hand with clinical evaluation. And remember that genetic counseling is paramount. You need to have a well-informed athlete in terms of the implications of a positive gene test, especially if they're phenotype negative. Gene positive does not equate to disease, but there are certain genotypes that we've discussed that require more caution. And if you're interested in reading a document regarding indications and utility of cardiac genetic testing in an athlete, then have a look at this document we published in the European Journal of Preventive Cardiology 2022, which discusses the impact of particular diagnosis on exercise, the impact of exercise on disease expression, as well as the impact of the exercise on the recommendations. And if you're interested in sports cardiology, I will invite you to join us during the ESC Preventive Cardiology in Ljubljana, 23rd to 25th of April. And we will also run a dedicated, very practical sports cardiology course the day before the Congress on Wednesday, 22nd of April. And if you're really interested in sports cardiology, also have a look at the MSc that we run at St. George's University in London. Thank you very much for your attention.
Και με αυτή την αυτή την παρουσίαση, η οποία ήταν ήδη recorded, φτάσαμε στο τέλος του session. Χάσαμε ένα τέταρτο αργότερα, κύριε Πρόεδρε. Θα μας συγχωρέσετε. Πάντα φταίνει οι προηγούμενοι, αλλά και εμείς βάλαμε το χέρι μας.
Εμείς το πήγαμε γρήγορα, αλλά...
Και να πάμε φτάνουμε σιγά σιγά προς το τέλος. Και ερχόμαστε να καλέσουμε τον κύριο Γιαννακούλα και τον κύριο Λάζα.